Well, simulation is well represented here today. So I'm currently working as an SPR in University Hospital Kerry. So I'm doing an out of programme year. And I'll also be working with maybe hopefully using some simulation in nursing home end of life care. But to come back to the presentation today, it's relating to a piece of research that I did whilst I was an SPR in Milford and UHL, and it was looking at the role of simulation in end of life care in the context of intern education. So just to kind of have a look at a high fidelity simulation suite. So on the left, you can see on the trolley here, we have the full bodied simulated patient who's plugged into all of the monitoring, and it's quite a realistic, clinically realistically environment. And then at the other side of the screen, we have a room which the learners can't see into. And we have the technician who is responsible for simulating the kind of the clinical signs, so cough and wheeze and that, and also the physiological parameters. So they're responsible for putting up the blood pressure and the heart rate and the oxygen on the monitor. And then next to them is the operator, who actually is the voice of the simulated patient and will interact with the learners. So just a bit about the background. So on the left here, we have a patient lying in this bed who's pretty shook looking, and it's not as a consequence of his illness, it's actually because he was inappropriately treated by an overly enthusiastic trainee. So, and the attitude then to the teaching hospital is, it's okay, this is a teaching hospital, some people just have to learn that the hard way. So I would use that as a segue to introduce simulation. It's an ethically more preferable to this scenario because it promotes immersive learning without exposing patients to risk. It also facilitates learning from scenarios which are infrequently seen clinically, such as death and dying. It provides a means of standardizing exactly what is taught to each of the learners. And most importantly, it has a proven efficacy in end-of-life care education. So our aims, first and foremost, we wanted to assess the baseline learning needs and self-reported confidence levels of intern doctors with regards to delivering end-of-life care. And then we wanted to compare the effect of a standalone lecture on end-of-life care versus a lecture combined with a simulation session on both the knowledge and confidence in relation to providing end-of-life care. And then finally, we wanted to elicit feedback on the simulation scenario itself and any psychological effects it had on the learners. So our methods, so we obtained ethical approval from UHL. Our population was that of intern doctors who were based in UHL. The inclusion was voluntary, and we obtained informed signed consent. This was a longitudinal study with 2 interventions, the first being the lecture, and then the other was the simulation session. So our data was by way of 3 questionnaires, which we disseminated in paper and also via Qualtrics. So we did our pre-study questionnaire, and that gave us our baseline learning needs assessment. Then this allowed us to quantify the number of patients at end of life who each of the doctors had cared for. And we also established the learners' baseline knowledge and confidence with regards to delivering end-of-life care. And then so we had another questionnaire after the lecture, and then another questionnaire after the simulation session. And then we also, during the simulation session, we handed each of the learners a drug cardex, which was the simulated patient's drug cardex. And learners were prompted to rationalise medications or to chart anticipatory end-of-life meds. So these cardexes were then collected and analysed, and they were part of our data set. So we looked at our data in Excel. So the performance in the pre-study was denoted 100%. So that was their baseline performance, which was a little bit risky because they could have went backwards, but luckily that didn't happen. The changes in knowledge and confidence was expressed as a percentage then of this baseline, and we conducted our statistical analysis on sigma stat. So then just looking first and foremost at the number of patients at end of life who each of the intern doctors had cared for over a 5-month period, we found quite a high level of variability. So 39% were involved in the care of 0 to 3 cases, whereas 40% were involved in the care of greater than 5 but less than 10 cases. So we looked at performance in a number of key areas pertaining to end-of-life care. And the yellow is our pre-study. And these areas are the ability of the doctor to address reversible causes. And the performance was actually, we collected the performance was based on a number of paper-based clinical scenarios, was what was in our survey. We also looked at performance with regards to prompting discussions about ceiling of care, recognition of signs and symptoms of death and dying, and then the pharmacological management of symptoms at end of life. So the yellow is what they would have had before they came into the study, pre-study, and the grey then, there's something funny with this slide, the grey then is actually the performance after the lecture. And you can see that there is an improvement in all areas, and overall it's statistically significant. Then next up, we looked at the drug cardexes that were completed in the simulation session. So we looked at the learner's ability to chart medications commonly used at end of life for given symptoms. And so the yellow is before the study, the grey is after the lecture. So there was an improvement. And then we can see that there's an incremental improvement in performance in this area after the simulation study. And again, this is statistically significant. We found that this improvement in knowledge was associated with an improvement, sorry, I don't know what went on with my slides here, an improvement in confidence, self-reported confidence. So the first bar chart is the pre-study. The next, there was an improvement in self-reported confidence after the lecture, and incrementally so after the simulation session. So with regards to psychological safety, the majority of learners, 73%, reported that they never or rarely found the session stressful. However, 11% found it occasionally stressful, and 6% found it stressful all of the time. And as my colleagues before me said, this highlights the importance of debriefing and ensuring that your participants have the opportunity to do this, and that they're leaving the session feeling heard, and that they've eased any distress they may have. So then, just discussing our main findings. So this study reveals that the exposure of intern doctors to dying patients varies quite a lot, and may indeed be an obstacle to acquiring knowledge and skills in the area. So we found that the acquisition of knowledge and self-reported confidence in relating to delivering end-of-life care was significantly enhanced by a lecture-based session, and incrementally so when this was combined with a sim session, and this is consistent with previous studies. The study also highlights, as I've said, the importance of debriefing sessions to ensure psychological distress is minimized. And again, this is consistent with other studies. Now, the limitations would be the small size. There was only 18 involved in the simulation session. Also, the fact that learners self-selected for inclusion. There's an element of selection bias. You could argue that it was the keen students who decided to go for this study. And then also the use of self-reported data. It's a subjective rather than an objective measure. Our conclusions, though, are that assimilation and end-of-life palliative medicine education enhances learners' knowledge and self-reported confidence. And we would hope that this is a potential to enhance transfer of skills to the real-world setting. Sorry, there was another slide, no worries. Okay, so thank you very much for listening.
Thank you very much. That was really interesting. I know we have this typical research thing about numbers, but actually, to me, numbers don't matter when the evidence is clear that it actually helps the people who wanted to be involved.
Yeah.
And as I mentioned to Anne, it's little acorns that turn into great oaks, and it's little by little by little by little we will enhance and affect change in how all of us when we start in our careers in healthcare, irrespective of our discipline, can actually improve and impact on end-of-life care. I'm really touched with that presentation. Any comment, Daniel?
Thank you. Jennifer, thank you for a really interesting and timely presentation. And just to affirm the work and to energise it, I hope we published a study last week in BMJ supported palliative care for 69 with 131 doctors in training. 69% indicated that they did not feel adequately trained in end-of-life care, and 68% that they weren't supported, and most said that the deaths of patients impact that the person lived. So this isn't, of course it's really important to support our doctors, that's really important, but even perhaps more importantly, this is going to lead to better patient care and experience. So well done, and thank you.
Thank you. Thank you.
Any other questions or comments? Yeah.
Could you tell us a bit more about the simulation? Like what happened?
Yeah, sure. So to begin with, they were given kind of what would be a realistic medical notes for UHL, and it was kind of denoting that it was an elderly gentleman who had been now in hospital for 4 months, and he'd had a number of episodes of hospital-acquired pneumonias, and the team had made a decision that he was on day 3 of antibiotics, that his antibiotics were not for escalation, and should he deteriorate, he wasn't for transfer off the ward to HDU or ICU, and it was the intern doctor who was called to review him. And it was firstly just what the intern doctor was prompted to do was to look at any reversible causes, such as fluid overload and that, and then to establish that no, actually this gentleman was potentially approaching end of life, and it was for the intern doctor then the prompt was to discuss with the registrar who was covering, to establish the ceiling of care, and then we went from there into communicating with over a mobile phone with which was great because it was actually the person who was operating the simulation was at the other side of the mobile phone to communicate with the relative. So we got that piece in there, and then the actual technical part of managing the symptoms at end of life. So I was actually the nurse as well in this. So I was a very stressed out, nervous nurse going, please, what are you going to do, doctor? What are you going to prescribe? And what I noticed was a lot of learners in these, when you're in the PowerPoint presentation, so they're very switched off, and they were a lot more switched on. They had access to their intern handbook. I think this might be kind of unique to UHL, and that had all the list of anticipatory medications there, because it would have been mean to have expected them to know those off by heart. But a lot of them as well, in the debriefing session, they did relate a lot of scenarios where they were solely involved in end-of-life care for patients, and they were really distressed by it, and they didn't have access to a registrar. So, and I've also been involved in kind of intern well-being sessions, which we do actually remotely with the Mentimeter, where they put in what's come up for them, and there is an awful lot of distress amongst our intern doctors. They aren't very well supported out of hours. Just the way that things are. So I know I'm digressing a little bit there, but I do think the NHS is very clear research that shows, if you can improve doctors' well-being, you can improve patient care. So that's it. Thank you.
Thanks, William. Thank you.
Thanks very much.